called pancreatitis, and there's also fluid in the abdomen and raised amylase level.
It's different because at that situation we didn't do a CT scan. For this one, we found the CT. We have
no. Consider we hadn't done a CT scan here also. Can we, in that case, when we are making a differential diagnosis, can we consider this also, polycystitis also?
Yes, you're right.
As a perfect cause?
Yes. Gallbladder stool, very common. What does it? It's a biliary ascariasis, and this is a patient. I did operation several years ago. So, but during the operation I found it. But before operation we don't know it. So we will review. So I review after operation. I review the imaging findings, and we found maybe not clear. Okay. And this is a patient. This patient discharged last week in my department. 3 weeks ago, when I was on duty, so this is an emergency. I met this patient in the department of emergency, and we after CT scan, not CT scan, just ultrasonography and abdominal puncture. There's a tumor rupture. Because this patient unknown, this patient just take a local CT scan film. So we didn't do CT again at night. So according to the local CT scan film, with poor quality, I guess this tumor couldn't be immediately. I mean, for emergency hepatectomy, it's impossible because the CT scan is not clear. Maybe we just found this area is a big tumor. Maybe another tumor will also exist in the other lobe, but no CT scan, no clear view. So we do TAC, we just do embolism to block the blood vessel to the tumor. And this is 1 week or 2 weeks after blocking. This is you see, this is the tumor, the lipodome. The blocking agents exist in the blood vessel of the tumor area. And this is still some blood. And this is a splenic rupture. This scan, you can see, change the morphology of the spleen. This is diagnostic laparoscopy. It's a high sensitivity with high sensitivity and specificity. It decreases the morbidity and the mortality, and it decreases the length of stay, it decreases the overall hospital cost. For some atypical patient, supports the pregnancy. The second is acute abdomen in the critical ill. Third is immunocompromised patient with acute abdomen. The final is acute abdomen in the morbidly obese. First, the pregnancy. Many lessons for pregnancy patients. It's difficult to diagnose the acute abdomen because they are delayed diagnosis. The underlying pregnancy has similar symptoms to acute abdomen, including pain, nausea, vomiting, and anorexia. And pregnancy can alter the presentation of some disease process and makes the physical examination more challenging because of the enlarged ureters in the pelvis. And the pregnancy can alter the laboratory findings such as the WBC. Pregnancy can influence the doctor's decision to perform typical imaging studies because of concern about radiation exposure to the developing patient. Very important. Also, for pregnancy women with pregnancy, if appendicitis and cholecystitis, the patient is very difficult for us to give medication to this patient. To control the inflammation is difficult. And the most common surgical disease seen in pregnancy, appendicitis, is the most common disease requiring surgery. And the pediatric disorder is bone obstruction. You will see it in your textbook. The reasons for delayed diagnosis could also be seen in acute abdomen in critically ill patient. Many of the underlying disease and treatment encountered in the intensive care unit ICU can predispose to acute abdominal disease. And critically ill patients are often unable to appreciate the symptoms to the same degree as the healthy peers because of nutritional or immune compromised, necrotic, and antibiotic use. The third is immunocompromised patient with acute abdomen. The reason for delayed diagnosis is immunocompromised patient has a variable presentation with acute abdominal disease. The variability is high correlative to the degree of immunosuppression, especially for transplantation recipient. Most common immunosuppressed patients are elderly, malnourished, and debilitated patients, and receiving liver or kidney transplantation, cancer patients with immunocompromised immunity, and HIV patient. Fourth is acute abdominal morbidity, morbidly obese. The reason is very obviously alteration in the signs and the symptoms of peritonitis in the morbid obese is difficult to touch it. Examining findings can also be difficult to confirm distension or intra-abdominal mass because of the size and the thickness of the abdominal wall. The dog is maybe 吉娃娃。什么意思啊？吉娃娃 Yeah. I have to tell you, I have 2 dogs in my family. I have 2 Chihuahua.
And Chihuahua is a small dog.
Small, very small dog.
Very small dog.
Very, very small.
The dog in Transformers, his mother had the dog.
Yeah, he couldn't find his dog. Abdominal images also adversely affected by toxicity. Okay, so the treatment for acute abdomen. I mentioned that the first responder's ability is very important. So the effective management of acute abdominal pain involves a careful history taking, ultrasound, and electrocardiography and blood tests. Okay. First, for acute onset severe generalized abdominal pain, we will see the algorithm. For acute onset patient, check. And if you found the newborn or peritoneal one, to go to operation. Don't hesitate to stay to keep the patient in the emergency department. Just immediately send the patient to the operation. And if you know no gas, no abdominal gas, and you will do. Sometimes you can do one suitable contrast swallow, but it's seldom to do it in emergency status. The second algorithm is special for gradual onset severe generalized abdominal pain. For gradual onset patients, MRIs, replace, and liver function tests are very important to check to confirm the existence of pancreatitis and other disease. For pancreatitis, normally we don't do operation immediately. We just send to do our CT scan to evaluate the severity of the pancreatitis. If minor, maybe just give some medical treatment. Moderate, actually, to how to classify mild, moderate, and severe. the most important tool is a CT scan. And the second, if we couldn't do it, we will, according to the clinical manifestations, the symptom, and the blood test to confirm. For severe pancreatitis, if we found a shock with respiratory failure, we consider peritoneal ravage. And for if MRIs replace liver function after detecting the fever, abdominal liver function, and cholangitis, for this patient, is very we should select a true choice. For example, if the patient is a high fever and jaundice, obstructive jaundice, and for this patient, pancreatitis after CT scan, pancreatitis has been diagnosed. So first we'll give enough antibiotics, and because obstructive jaundice, and it's maybe stone or other things stayed in the CVD and cause pancreatitis. If we don't take away the stone, the pancreatitis will aggravate, and the inflammation will increase. So the very, very first step is to take the stone out. So one way is the operation, but because the patient, the condition is not good, because pancreatitis is a generalized disease. Sometimes the patient is elderly, so very, very useful tool is ERCP to take the stone and put a drainage tube to decrease the jaundice. Maybe 5 or 1 week later, the inflammation will decrease. And then, maybe 3 weeks later or 1 month later, you can do this, to do the operation to cholecystitis. Okay, for the right upper part, abdominal pain, so what we will do, according to the history and the physical examination and the laboratory findings, if we couldn't find anything, so you will do even the detect normal, we will do ultrasonography. If we find a gallbladder cell, we will do a laparoscopy. And then, if no finding, we will do CT scan to detect that. Maybe we'll, according to the findings from the CT scan, to make decision. If we find increased liver function and but normal analysis, we do ultrasonography to check it. To according to finding of imaging findings to make decision. And this is the algorithm for left up part. Is according to history and physical examination. Finally, this part, because in this part, sometimes we will do a CT scan, and according to the report to make a decision. This is for right lower quadrant abdominal pain. So for female and male, it's different. Okay, appendicitis. No appendicitis, and to make a choice. Just a question, single show. This is for left lower quadrant abdominal pain, peritonitis and non-peritonitis. Many digestive, other kinds of digestive disease. But for peritonitis, imaging finding showed for operation you have to go to do emergency operation. If we found some abscess, just very close to the appendix or serious, so you will do. You don't at this moment. You don't need to do operation immediately. we will send it to the ward, clinic ward, and give strong antibiotics and some Chinese traditional medicine. It's very effective to control the inflammation in abscess. Very useful. And also for some obviously abscess, some fluid correction, you can do percutaneous drainage. For some special patients, maybe 1, 2 weeks or 1 month later, the abscess will obviously decrease and disappear. You don't need to do operation. But if you found if it's a pancreatitis, if it's appendicitis still exists, and you have to do final maybe several months later, we need to do the resection to resect the diseased appendix. Otherwise, sometimes some months later, the abscess will recur. And for emergency operation, what we will do, so this is a preparation including intravenous access. We have to establish enough intravenous access and antibiotics infusion, nasogastric tube, folic acid blood drainage, and hydroelectronic equilibration. Also, we have to prepare cross-matching blood to make it available. For example, to do emergency operation, very important, the first step is to make adequate enough exposure. Okay? This is very important to do operation. For this young man, 5 years ago, is my patient. Traffic accident incidents, and this patient was sent to local hospital to receive the emergency operation because liver rupture. But the doctors in the local hospital couldn't control the bleeding in the operation room. So many gauze press the bleeding and sent to my hospital immediately. So we found that, but actually the bleeding was controlled by the gauze. But we have to take the gauze out. This patient couldn't keep the gauze for the whole life. So I put the gauze little by little, step by step, and found it's 2 meters long. Very, very long. Yeah, very long. Many gauze. And the patient, we have to do a re-operation for this patient because severe infection. Because this is a many necrotic liver tissue with infection. So we have to do operation to take away all the necrotic liver tissue to control the infection. So during the operation, this is necrosis of the liver tissue. We take all and they do suture. Because in local hospital, the doctors would like to control the bleeding. They do a very big suture and many bigger vessels were obligated. So the blood supply and the outflow of the liver was damaged. So many tissues will be necrotic.
The yellow things.
And the yellow thing means inflammation or infected necrotic tissue. Acute necrosis, chronic necrosis. Chronic.
No, because you send it immediately to you then.
Yeah, but stay in my hospital for maybe 5 or 1 week because of it's an uncontrolled infection we did the operation.
So the operation was done after 1 week.
1 week later.
And the bleeding was controlled by the gauze.
Yes. Yes, the gauze stayed in his body for 1 week. So I will do a summary for acute abdomen. acute abdomen remains a challenging part of the surgeon's practice. The key point is a patient with an acute abdomen is an emergency, and it is imperative to get a correct diagnosis. Also advanced in imaging techniques, a careful history and physical examination remains the most important part of the evaluation. To perform a laparoscopic or laparotomy for diagnosis with a good deal of uncertainty as to the expected findings. And we will do this case. Yes. For example,
in traffic accidents and all the emergency surgeries that you need in China, so how is the triage system in China regarding those surgeries? Triage.
What does it mean?
And which hospital should we send? Like,
I mean, if a patient has, if a patient went through an accident, right, and he needs to go to an emergency surgery, which nearest hospital does he go to, or which treatment is best suitable, very initially, or the first step in the process?
Yes, yes.
And like beforehand, you talk to the hospital that I have a patient who is, what is his condition, vital signs and all that, which hospital is better equipped for this patient to handle the patient and all these things. So do we have that system in China?
Yes, we have a system, but the patient has the power to select. So normally the patient will decide, because for some emergency case, they would like to go to a very close hospital. And then if the hospital says you have to go to bigger or very high level hospital, they will transfer you out. Because for emergency, it's dangerous to transport for long distance. So for example, the young man.
But what if a hospital is close to the patient, but hospital does not have the facilities to take care of the patient, then what's the use of making that?
Yes, but the hospital have to try to treat. Some patients could be treated, but some of them couldn't be treated and have to be transferred to us. Yes, we have the system, but according to the emergency situation, the patient it's better to transfer the patient to a very close hospital, because time is very important. This is 20 years old male with a longer period for 18 hours. The patient study is a bit of and it's constant. Now let's customer anorexia, and vomiting. This is the first episode for the patient. No diarrhea, just urea. The pain now seems worse in the right lower part. And the doctor did a physical examination.
pain now sleeps more than I thought.
The patient lies flat, avoiding moving, and epiblind, and abdominal tent mostly in the right RAQ, and a significant guarding. Positive for locking side. Do you know locking side? Press this area and it's
appendicitis. Is it appendicitis? Pain at the McBurney's point.
Yes, yes. So if you put this area to control, and the other part, the opposite part will pain. Positive. So the volume from WC is increased. ASTM is normal, everyone is normal. Urine count is negative. And so the first testing, for example, CT scan, this is CT scan. And what is the diagnosis? But from now, it's difficult for you to read, for CT scan reading. But according to the whole history and the examination, you will know what's the diagnosis.
Can you see over there the appendix?
Yes, they are diffusion around the area. The second part is the appendix. Okay. Appendix. Okay. Appendix. And this is appendix artery, vessels, and this area is the mesoappendix. Appendicitis. This person first described acute and chronic appendicitis in 1989, 96. It has been recognized as one of the most common causes of severe acute abdominal pain worldwide. Appendicitis is a condition characterized by inflammation of the vermiform appendix. All cases require removal. Normally, all cases require removal of the inflamed appendix, either by laparotomy or laparoscopy. Untreated, if untreated, maybe 50 years ago, in old China, 50 or 60 years ago, many deaths directly related to appendicitis. Mortality is high, mainly because of peritonitis and shock. First is anatomy and position. Second is pathophysiology, diagnosis, and differential diagnosis, treatment, and outcome. First, anatomy. As you know, appendix is a close-ended narrow tube up to several inches in length that attached to the xylem like a worm. Length 5 to 10. Diameter 0.5 to 0.7. The inner line of the appendix produces a small amount of mucus that flows through the open center of the appendix and into the cecal. The wall of the appendix contains the lymphatic tissue that is part of the immune system for making antibody. McBurney's point means 1/3 of the way from the anterior superior iliac spine to the umbilicus. So, this point. The position. The vermiform appendix has no constant position. The appendix is normally, in China, is more often found in the pelvic rather than the retrocapsular position. With 5 common positions. First is a post-ilial, pre-ilial, according to the position with ilium, and retrocecal and subcecal. This is pelvic. I got a date from north of Iran, you can see. So I think the position of different kinds of position of appendix differed from different person, different area. For Iran, you see, although pelvic is major, but retrocecal is also many persons has this kind of appendix. Okay. And the acute appendicitis is thought to be benign with obstruction of the lumen.